I can go first if you'd like.
Sure.
All righty. Let's see. You should see my Cyrix screen. Okay. So let's start with this first case. So this is an uh, elderly male patient who fell from standing um, and was seen in the emergency department. You can see he's had, oh, you don't see my images yet. Hold on. There. You can see a radiograph now.
Yep.
And you can see he's had previous heart surgery. He's got one of these new atrial septal occluders. I always think it looks like a toboggan and whatnot. And we don't see too much. You really don't see much on the radiograph. You can see he's got a lot of osteophytes in the spine. But what's interesting about this case is the injuries we do see. And I'm going to show a sagittal once it loads. He didn't have any lung injury or anything like that. But on the sagittal, so it reslices for me, you'll see there's this unusual fracture going, hold on, let me bag it up here, going through the thoracic spine, sort of extends from the ossified anterior longitudinal ligament through the disc into the vertebral body, through the disc space and into the level below, and then sort of out there. And so he's got diffuse idiopathic skeletal hyperostosis, DISH, which in my past experience never thought much of. It was more of a description I remember learning about as a resident, but we didn't talk about it very much. But I know in the patients here, they're very, these patients are at high risk of spine fractures, even from minor traumas. And this is a nice example of an unusual fracture in that it sort of crosses a disc space because the spine has become so rigid in this area that I guess the force is transmitted through it, not your usual transverse process fracture from just a low energy trauma. So it doesn't take a lot. And a lot of times they're older, so they're also osteopenic and so at higher risk of fracture. But I don't know if you guys ever come across these. I know, Howard, you see a lot of trauma.
I don't think so.
Yeah, so I have to pay more attention to the disc, I think. Luckily, the spine is usually carved out and read by the spine people, but they don't always, and these low energy ones don't always do that. So, yeah, and so looking around a little bit in the literature, they are at increased risk of fracture. So it's different than ankylosing spondylitis, but probably has similar mechanical implications in that the normal flexibility of the spine is lost in certain areas. But the clue in this case was the broken, flowing osteophyte, and the step off from that, so that there was clearly an injury there.
Yeah.
All right. This is something we've talked about recently. This is a middle-aged woman who came in the emergency department with shortness of breath, little chest discomfort. And this was the radiograph, and it was reported as no acute abnormality. I would agree with that. We don't really see much going on. The lateral isn't particularly helpful either. But so she had a CT study for pulmonary embolism, and we found the cause of her shortness of breath. She's got this peripheral ground glass opacity, primarily in the left upper lobe. It's perilobular, sort of arcading along some lobules, along the bronchovascular bundles. So a good look, and very patchy with normal lungs. So a good look for organizing pneumonia. And at the time, originally when I looked at this, the resident had reported it and described it. We didn't know much more about her, but favored infection or something like that, which I think would be reasonable. It's not the most usually I think of infections that look like organized pneumonia more bilateral, but not impossible. But we found out a little bit later when the resident spoke with the emergency medicine physician that this patient had been recently treated for a low stage breast cancer with radiation just in the past few months. So no chemotherapy. So this is presumably radiation-induced organizing pneumonia from breast cancer, which is very well described in the literature. I just haven't seen a case in a long time. And I was wondering if they had changed their technique at all, but in this case rolled around. And you wonder, given that most of the abnormalities in the subpleural lung, if that's where it started and just spread out. And I wasn't able to get the plan to see if they had radiated the axilla or not. I don't think they did because I think it was a low stage, but sometimes you see that when they do the axillary boost, you get a lot more in the apex as well.
But Jeff, don't you think this was tangential radiation for her breast cancer?
Yes,
left breast cancer?
yes, I believe that's what it was. But the organizing pneumonia occurs outside initially at the area of radiation, but promptly moves to the outside the field and even to the contralateral lung. I think she's starting to get a little bit in this right upper lobe, maybe, maybe not, but it's a little dense in a few spots. But it went along with it not having a leukocytosis, not really acting infected, no drugs, no connective tissue disease. So usually managed with steroids, and it'll with a good outcome.
And you mentioned that the radiation was relatively recently.
Yes, it was in the last I think it was in the last 4 months, and it's been reported to occur up to a year out, depending. And a lot of times it may be triggered by that. When we talked about that recall pneumonitis, it may be triggered in patients who had previous radiation who then get chemotherapy, maybe a drug that's not particularly associated with lung injury, but sort of pre-primed lung. But this occurred in isolation and has been pretty well documented. Okay, this is another interesting case. So this is a 76-year-old man who presented with fever. He's got known renal insufficiency because of a small vessel vasculitis. And you can see here he is in the hospital, and he has this cavitary nodule. He's got these other nodules and masses in his lung. So you might think, well, this could be GPA, granulomatosis polyangiitis, would explain a small vessel vasculitis of the kidneys, lung nodules, and some cavitary things. So here's a CT from a little bit earlier. You see he's got pleural effusion and this dependent lung disease, consolidation ground glass. And then he's got these poorly defined cavitary nodule left upper lobe, and it maybe looks like some pulmonary hemorrhage or something going on. So, or just all edema, and sort of a renal edema that can be quite nodular. And these kind of got bad really fast. So here it is 12 days later, and this thing's a lot bigger. You got this thicker wall. He's got this other nodule here. So, GPA would be a good, and then this big mass-like area here. But the funny thing about it was what his head looked like. So they did he was acting, he had some neurologic findings. So he got a brain MRI. And I got to make sure I get the right sequences. So this is a pre-contrast, and you can see there's this cerebellar sort of vermis lesion, this low attenuation, low signal centrally, and more intermediate signal around the periphery. On the post-GAD, there's this sort of rim enhancement around it there. And then this, I think, is a fluid-sensitive sequence. You see a lot of, very low signal within it there. That's the post-GAD as well, sorry. And then there's some restricted diffusion in there, and it's been a while, but there's signal dropout in that area there.
And no sinus disease on the study.
And no what?
No sinus disease?
No sinus disease. You can see there it is there. So it's a lot of high T2 signal there. So, not a great fit for GPA in the brain. So the other thing to consider, because he had gotten several doses of rituximab, and then he was on corticosteroids, would be not GPA in his lungs, but rather an infection. Indeed, this ended up growing out aspergillus, but it's a really ugly looking aspergillus. So some of it is cavitary, some of it is more consolidative, and it may be there's other organisms in there, but the bigger nodules, they got hyphae, they got positive galactomannan, so I mean all the things fitting with it being aspergillus. So the presumption is this was an aspergillus lesion in his vermis as well. But we see a lot of aspergillus, but this one kind of was a little unusual in that it looked uglier than many of the aspergillus cases I've seen. It's really just ugly, thick wall cavity. So, this is just a nice example. It's not a diagnostic dilemma. Younger patient, I think, I can't remember how old, 32, presents with this big lung nodule on the chest radiograph, and backwards lateral, but there it is. Outside CT, so thick cuts, but really nice example of a pattern of calcification that's not considered benign. It's sort of amorphous, not central, not target-like, and this sort of large heterogeneous nodule. So non-smoker, a little bit of obstructive phenomenon distal to it. So, and then had a PET, which shows just not much uptake in the MET. So a nice look for a carcinoid tumor. This is a typical carcinoid, but had some of the prettier so-called indeterminate calcification patterns, not really stippled, but more amorphous, like, almost like you see with osteoid when it's got that cloud-like appearance to it.
Yeah. Very nice example of that.
Yeah, I'm not, I've seen a little calcium here and there, but this is probably one of the better examples I've encountered of real convincing calcification of a carcinoid. Okay, this is an interesting case, and this is a lady who's seen in our pulmonary clinic, transplant evaluation for pulmonary fibrosis, and you can see the distribution is very upper zone. She does have a history of a early stage breast cancer. So it looks like an upside down UIP. It's peripheral, but it's apical predominant. And this was her most recent CT that I looked at. And you can see there's, as we'd expect, this extensive biapical. There's traction bronchiectasis. There's just this dense fibrotic tissue, not the typical fine reticulation. And there's a lot of volume loss in the upper lobes. And I'll show the coronal in a minute. But what took me as being a little bit odd is you got some, that's probably traction bronchiectasis, bronchiolectasis, maybe what you might call honeycombing, but as you go down, it looks more like peribronchial and peripheral disease, like a fibrosing organizing pneumonia or NSIP spectrum. It is more subpleural in some areas, but it's often awfully confluent there. So I wondered about a connective tissue disease or something else. I didn't like it for UIP, clearly based on the distribution. No exposures. I usually see more central disease with HP in the upper zones. There's a little bit, but not a lot. So she ends up not having anything. And this upper lobe stuff is a nice example of pleural parenchymal fibroelastosis, which can exist by itself or in conjunction. It's been reported in conjunction with UIP, both pathologically and on imaging. And in this case, had I not had the upper lobe stuff, I would have favored this being more on the NSIP sort of fibrosing organizing pneumonia spectrum. But the predominant volume loss is in the upper lobes. She has severe restrictive physiology, very short of breath. So sort of a mixed pattern, but with clear features of PPFE and no known cause. So it is in the current ATS ERS classification as one of the rare ones as idiopathic PPFE. This is one of the more striking cases.
Was there biopsy proof of this PPFE?
No, she's too sick, and it's not going to change anything. If she gets a transplant, we'll hopefully have proof, but it's a good look.
Mm-hmm. Yeah, one other thing I generally think of nowadays for unusual patterns is familial pulmonary fibrosis.
Yes.
That can certainly have very unusual patterns that are
right. Even differing patterns among siblings or relatives, even though they have the same. Travis showed those twins who have the telomere deletion or mutation, and they had totally different pathology and different lung appearances.
Yep.
All right, and then this last case I sent to some of you earlier. Travis isn't on, but Seth was kind enough to get a chance to look at this case. So I'll show what I can. This is a 42-year-old woman, history of methadone for chronic abdominal pain, alcohol abuse, not currently smoking. She had an old abdominal surgery for peptic ulcer disease, but she came in cardiogenic shock. And on echocardiography, her ejection fraction was in the 30s, had been in the 60s about a month ago. And so she required mechanical ventilation, pressors, and with medical management, she's now off the ventilator, and they've managed to reduce a lot of her afterload with some beta blockers and all that fun stuff. So she's doing better, but they managed to get her in for a cardiac MRI the other night. And I'll just show key sequences here to try to get a sense of what's going on. The thought is that she's presenting with an acute myocarditis. So this is a cine loop here in the short axis, and let me brighten it up a little bit so you can see it. So there's a couple things we can see once it plays through the circuit here. Is there's some hypokinesis, particularly along the lateral free wall, the inferior wall. You can see this, even the septum. There's kind of a global hypokinesis, but pretty good contraction at the apex there. And then let me pull up the post contrast here. long axis. Yeah, you can see there's delayed gadolinium enhancement, sort of mid-myocardial. Interestingly, spares the apex, which is a little odd. And then on the short axis, if I can find, yeah, you can see here, it's just quite an impressive amount of delayed gadolinium enhancement. You can see the endocardium and the epicardium are relatively spared. There's a lot of breathing artifact, but it's sort of a diffuse left ventricular myocarditis, and then a little bit of sparing towards that apex there that we saw on the other ones. So my colleagues who looked at this, in their experience, haven't really seen a case with this florid amount of gadolinium enhancement. But Seth said he's seen a couple of cases, and she's going to get a follow-up afterwards. I'll be on the lookout for it. But to see what's kind of left, how much injury there is to the myocardium, it's unclear. But the presumption is this is a viral infection. It is that time of year we see some of the Coxsackie viruses and other enterovirus infections. And with her alcohol use and stuff, she's probably got some degree of immunosuppression or dysfunction. But quite an impressive case.
Yeah.
All right. That's what I have this week.
Those are very interesting.
All right, Howard.
Could you try that again, because the share button that I usually click is grayed out at the moment. Thank you.
Not working?
Yep.
All right.
Okay, this first case is a trauma case that's got some really strange features, and I try to find more details about what happened on the outside, and I was not really successful. But suffice it to say that this person was apparently involved as a motorcycle rider in an accident in which he ended up being knocked off his bike, but even trapped into literally in the grill of a vehicle that carried him some distance. So bad injury, motorcycle, and he came from the outside. And let me show you some of the outside images. So I'm going to try and get this right. So this includes the chest, and here is the sagittal. Let me put the sagittal up here. And then I'm going to mag this one up because it's small, because it's the whole chest and abdomen. So let me bring that down and do that. Now, looking at the axial, there's an interesting finding up here that is in relation to the upper thoracic spine. There is abnormal opacity here in front of the spine going on either side of it. Trachea is obviously there, esophagus is somewhere there. So that abnormality here, in terms of where it's located, now I'm just going to localize that on the lateral. And when I do that, this crosshair will show what area it is. So it's right here. And now looking at this disc space here, let me see if I can make that go away. Notice that the disc space between this vertebral body and this one is widened here. Okay. So at the site of this finding, we have this anterior and bilateral opacity. And then you can see the fat is effaced. There's more of it there, but it's particularly centered up right here, corresponding to this level. I will tell you that later on he had evaluation of the spine again with CT and an MRI. And on MRI, apparently he had very florid findings consistent with a injury that extended all the way through this disc space from anterior to posterior. And there was a lot of soft tissue abnormality there. Although, as best I can tell, he wasn't paraplegic. So his neurologic function was apparently intact. but he had very clear evidence on MRI, particularly of an injury that went all the way from anterior to posterior. So let me now show you, going ahead in time. I'm going to skip something just for the moment to show you that at a later time, look at the abnormality in front of that vertebral body. So the time now is, between these is 8 days. And I think he was initially actually discharged from that outside institution for a time, but then came back. And I don't know to what extent his symptoms related to what I'm going to show you right now, which is the esophagus. So look at this. Here's an esophagram from the outside. And you can see that he has a transmural laceration of the entire esophagus right opposite that disc space, with the contrast medium coming out of the esophagus on both sides. So this is a strange form of spinal vertebral injury, but it lacerated the esophagus to produce this pretty dramatic injury. And that was subsequently repaired, or they attempted a repair of that, but they did find that the esophagus was lacerated, as you can see there. So I'm not quite sure what to make of this case, but it's a tremendous soft tissue injury that did that. And I don't think it was infected, but I don't think I've ever seen that before.
So Howard, do you think it was sort of a rapid deceleration in that big osteophyte that you showed us on the sagittals, just ripped the, act like a razor blade with that, and ripped that, ripped the esophagus at that point?
Yeah, I don't know. Because I think on MRI, there was injury involving the disc space and the posterior portion of the spine, at least the soft tissue components of it.
Yeah. Because if you look at, I mean, his lower spine, he's got some dish.
Yep.
So he doesn't quite have it all the way up, but he probably had some abnormal mechanics there. But if you look at that, the original sagittal, there was that osteophyte's quite, it's got quite a sharp convexity there. You wonder if it just slammed right in there. It sounds like it was pretty high energy trauma.
Yeah, some high energy injury.
Yeah, see, it's got those. Maybe the disc injury happened first, and so you got those sharp. And you wonder if that osteophyte fractured, given how the other ones are at least articulating or close together, and it's got a sharp edge, and it just punctured it. Because look, if you look right, and there's a little sliver of gas just behind the trachea, and that may be intraluminal. That may just be the normal limb. So it's possible.
Yeah, I think that's intraluminal.
That it just didn't. It wasn't visible at the time because it was maybe because of the hematoma around the spine. It sort of tamponaded any.
Yeah, right.
So
So kind of a.
I'm sorry.
Go ahead, David.
On the later CT, do you think the gas was getting into the spinal canal?
Let's have a look again at the later one. We'll go to 614.
You don't want an esophago spinal fistula. It looks as if there is gas in that.
No. It goes, yeah, I don't really know about right up here. It certainly goes there, and there's that. I don't know about that, for example.
Wild. Well, they used to call motorcycles in California in the early days of a heart transplant, they would call them donor cycles because they were such a good source of, healthy young hearts and people who had, cervical spine injuries or brain injuries that killed them. You could harvest the hearts. Motorcycles are terrible.
Yeah, dramatic, huh? I think he went home, and I don't know if he had esophageal or swallowing symptoms, but I think he may have. That made him go back to the outside hospital. And then when they discovered the extent of the injury, they transferred him here, and he got some further imaging there. So that's on 6/13, and the time of the initial injury, where the esophagram showed that injury, was back on the 6th. There was a week interval between that, and it's not really clear to me exactly what happened in that week interval, but I think he was actually discharged with no neurological injury. He went home. Wow. And he may have come back more with esophageal symptoms than neurologic symptoms, and then got that esophagram, something like that. That's pretty dramatic, isn't it? So maybe the osteophytes played a role in the distraction injury. I'm not sure what to call that injury. It goes through that space, and this is wide, and that's the injury. That's
Have
Pretty
we done
dramatic.
a case of an aortic injury from the osteophytes? I can't remember. I have this vague recollection that there was another one of these osteophyte-induced injuries. I'm guessing not, since nobody remembered it. But
I'm going to try to find out how he's recovered from this injury. Maybe he's going to be very lucky indeed if he's recovered from the surgery to the esophagus. And I don't know what his neurologic state is now, spinal injury-wise. Pretty dramatic. All right. Let me show you two nice examples of patterns of metastases and how they may grow. So for neither one do I have pathologic proof, but I'm pretty confident that I know what's going on. So let me show you two images in a patient with metastatic bladder cancer first. And let me separate these and bring them down and do that. So here we are in April, and then the follow-up will be in June. So not too much time between these two. And that's what his chest looks like there. He's got a little bit of pleural fluid. I'm not sure what that is. But the dramatic change in the chest is the development of all these opacities. So you can see diffuse or just multifocal, multilobar, new opacities. Now let me mag this up. And I'm pretty sure that many of these, maybe almost all of them, are actually intravascular metastases. So for example, if you look at this cluster up there in particular, but also some of the others, I think one can appreciate that these are tubular opacities. And some of them have, like that one there, I think Jeff calls these shaggy margins a little bit. And you can see, but otherwise very typical for vascular tree and bud type of opacities there. There's a bit of motion and sharpness, but here's another large focus there. So looking through the motion and sharpness, you can see that again, I think we have very distended vessels with shaggy margins. Some of the margins may be motion, but otherwise, most of these are vascular lesions growing in the vessels. Some are just plain nodular as well. But I think a very dramatic example of the rapid growth of metastases, but particularly intravascular metastases.
Howard, was there a change in the right heart caliber that you could appreciate?
Let's have a look at that. As in, does he develop things, say, pulmonary hypertension, say? So let's look at the overall appearance of his right heart between the two. It's got a bit more pleural fluid. In terms of ventricular or atrial enlargement, for example, not particularly that I perceive.
Yeah, it looks pretty similar.
Yeah.
Looks
And
as
then
if
I don't know the etiology of the pleural fluid that he has as well.
his heart's bigger in general.
I think it's a bit bigger. Yeah, I don't really know what's going on, because this will be left heart here. I don't know what's going on there.
And what about pulmonary artery? Did his pulmonary artery get bigger?
Just eyeballing that? Yeah, not really.
Not the same.
I'll see before I share this where I can find any cardiac ultrasound report, for example, to indicate
You know what
the
else is
development. Eventually.
interesting?
Go ahead, Jeff.
Go back to the lungs. You talked about the shaggy margins. The other thing that I find helpful is distinguishing these from airways is the veins. You see these little side branches, especially when you zoom in, you can see these little side branches coming into the abnormal vein that you typically don't see. It's sort of like, the equivalent of a bronchiolar impaction where you normally can't see the bronchiole. But like right there in that left upper lobe along the fissure, you get those little tiny side branches coming in that are probably dilated venules that we don't normally see because there's distal tumor.
Yeah, something like that.
Or there's tumor, I should say, tumor upstream that's then leading to the obstruction. So
yeah.
you see them out in the periphery of the right upper lobe too in that image.
Yeah,
little tiny
in
veins going towards the pleural surface.
the coronal image of that. Yeah, I think you're right about the shaggy vessels. It's hard to separate out venules from arteries. I have to look more carefully to see if I can figure it out, but it may be really hard to tell. But I think we all agree these sure look like vessels. Veins, venules, arteries, arterioles, maybe both. Even this one's a bit shaggy, isn't it? Slightly. But I thought a nice example of that phenomenon. Okay, let me show you this one. This is a patient that has a biliary tract cancer, and this person's had it for some time. You can see from an image like that that we do have biopsy-proven pulmonary metastatic disease. But the growth of this over time, as the disease has gotten worse, is quite dramatic and quite instructive. So let's go back to the earliest one that I have here at the moment is 2017. And even this, in terms of the pattern of disease, is really interesting. So we have a lot of target type lesions, solid centers with ground glass halos. And a lot of the lesions are just like that. There are other lesions in which there's a lot of ground glass opacity as well. Maybe some other lobules where we don't necessarily have a very attenuating center, but a lot of them have that bullseye kind of appearance, at least in terms of having a halo of ground glass. And then we have a more extensive area in which at least maybe 2 lobules worth of opacity, ground glass, and then more solid. But that is a really interesting pattern in and of itself. So usually when we have these, we think about lesions such as, if I remember correctly, maybe metastatic angiosarcomas, choriocarcinomas, for example, that can have this kind of appearance. Now, compared to that one, I will show you going forward in time. Let me just bring up the last one where we have a pattern of dramatic growth of the lesions looking like this.
Wow.
Now it's become very confluent. So what I believe is happening is that what is really growing is the ground glass component, and I think it's lipidic growth. So I don't know why, but in this person, I think the tumor cells are growing in a lipidic fashion, and it's the same basic pattern, but the overall amount of tumor, of course, is much more. Both components are growing, but I think this is, in particular, lipidic growth of tumor.
Howard, you said this was cholangiocarcinoma?
Yeah, biliary tract cancer. Yeah. And the time here is that.
Yeah, I saw a case of choriocarcinoma on Monday that looked like your case there with the halo, but the thought is it's hemorrhagic. But you would think they would change over time if they're truly hemorrhaging.
Yeah.
And I can't imagine they're all hemorrhaging at once. So I wonder if there is some component of either vascular invasion or lipidic growth.
Yeah, I see a repeat biopsy was done in March of this year that showed the tumor, and you can see which lesion they got there in the, maybe the right middle lobe area somewhere, or the patient's prone. Yeah, but I like to think this is a dramatic progression, but with a very conspicuous pattern of lipidic growth of tumor, particularly, but also more solid components, both. Yeah, the last one I saw that was very, very similar to this one was a pancreatic adenocarcinoma.
Yes, I think I've seen that. I think I've seen that with pancreatic as well, Howard. And our pathologist here made the point years ago that metastatic adenocarcinomas can grow with a lipidic pattern. So he's seen it before. I've seen it before, and it makes sense. If you have cells that are fairly well differentiated and they still sort of want to adhere to surfaces and things like that, then they might as well grow along alveolar walls and stuff like that the way an adenocarcinoma of the lung would. So I think it
Yeah.
depends on how well differentiated the tumors are, whether they still like to be connected to something and not just be a big jumble.
Yeah. And I'm not showing you all the images here. There are images from before 2017. So this is a person that's had quite a long survival for so much tumors. They seem to be growing, at least in the lungs, relatively slowly over time, not very aggressively. There is presumably some growth of nodal tumor there over time, but a very interesting pattern, right? Very interesting.
Excellent example. That's beautiful.
Yeah.
It was you said biliary tract's like a choriocarcinoma. I mean, yeah, cholangio. I mean.
Yeah.
Okay.
I did see the word pancreatic or biliary in her chart, so I'm not quite sure whether there was a question of whether it was a pancreatic or external to the liver biliary tract cancer, but she's been labeled as a biliary tract most recently. All right, Jeff, those are mine for this week.
Well, thank you. All right. Well, good. We managed to cover a lot of time with cases. So, yeah, next week.
Very good.
All right. Take care, everybody.
Okay. Thanks, everyone.
Thank you.
Bye.